Hi, everyone. My name is Ashley Santora. I am one of the students here at Regis College in the nurse practitioner program. I apologize for my voice sounding like this. I'm at the tail end of a respiratory infection, but starting to feel better. I'm going to dive on in. This is week 11 in our pharmacology class, and we are reviewing a case study on Emily for treatment of impetigo in an 18-year-old female. So Emily Davis is 18, diagnosed with impetigo, and she comes to the clinic with multiple honey-crusted lesions on her face and arms. These lesions started about a week ago and have been gradually increasing in number and size. Emily reports mild itching, but no pain, no fever. She has no history of allergies or recent skin trauma. Emily is otherwise healthy with no significant medical history. First line treatment is we would recommend topical mupirocin, which is also known as Bactroban. It's a topical antibiotic. Mechanism of action binds to the bacterial isolate transfer RNA, resulting in inhibiting of protein synthesis. For the pharmacokinetics, it penetrates the outer layer of the skin. Systemic absorption is minimal through the intact skin. Metabolism, it's minimal absorption with rapid conversion into inactive products. It mostly is excreted through the renal system through our urine. Pharmacodynamics, mupirocin works locally by stopping susceptible bacteria from making essential proteins, which clears the skin infection. This is actually something we see very often in my pediatric office that I work at. Impetigo is something that is seen, I would say, at least once or twice a week in office, and I'm always amazed by how quickly the mupirocin works. A second line treatment for Emily would be an antibiotic such as cephalexin, also known as Keflex. This is the first generation cephalosporin antibiotic. Mechanism of action is it blocks the activity of bacterial enzymes in the tRNA, which prevents the production of essential proteins. Without these proteins, susceptible bacteria are unable to grow and are eliminated. Excuse me. The pharmacokinetics, it is rapidly absorbed, about 90% orally. It's widely distributed through most of the body, through the tissues and the fluid. It has a half-life, we're going to look at just for adults because Emily's 18, for about half hour to an hour, 0.2 hours, mostly excreted again, renal system through the urine. For the pharmacodynamics, cephalexin inhibits bacterial cell wall synthesis by binding to the penicillin binding proteins, preventing the formation of stable cell wall. As a result, the weakened bacteria eventually ruptures and dies, which is what we want. For my prescriptions, I do think the way that Emily is presenting right now, we could start with just the topical mupirocin antibiotic. I don't think as of right now she needs the oral one. So for the first prescription, we would prescribe mupirocin 2% ointment, apply a thin layer to the affected areas 3 times a day for 5 days, gently washing and drying the lesions. We also want to wash our hands before and after applying the medication. We would dispense a 22 tube, and if we would give clear instructions, if we're not seeing any improvement, we have failure for the topical antibiotic, then I think we can talk about going to the Keflex. Or if she came in and there was more lesions throughout her whole body, and she also had some systemic symptoms, she had a fever, other presentations, then we can talk about doing both prescriptions. So I did also write one for the Keflex. And with Keflex, I wrote 500 milligram capsules, take 1 capsule by mouth every 12 hours for 7 days, can be taken with food to reduce stomach upset, and we always want to complete the full course of antibiotics. Now, for this one, there seemed to be some difference in prescriptions. You could do 500 milligram capsules that did say every 6 hours. I went with every 12. I just figured right now, where this is maybe a second option, we could always revisit it and discuss what we felt like was the best option for Emily if it was needed. For drug interactions and adverse effects, for the mupirocin, there's no food interactions and no interactions. We do want to avoid mixing with other topical products, especially if you have any creams for like eczema or anything like that. We just don't want those to interact. It can cause a lot of skin irritations. An adverse effect would be skin irritation, burning, itchiness, dry skin, headaches, nausea. For any medication, there's always a risk of an allergic reaction. So we always kind of just talk about the signs and symptoms of that and when to call the office and when to seek emergency care. Less so with a topical ointment. For the cephalexin, there's no significant food interactions. It can be taken with or without food. Sometimes we suggest with food just so you don't get any GI upset. Drug-to-drug interactions, cephalexin has minimal drug interactions, but should be used cautiously with anticoagulants such as warfarin because it can increase the risk of bleeding. When prescribing any oral medication, we always want to just review what other medications they may be taking, just to ensure that there's going to be no contraindications or interactions. Adverse effects could be abdominal pain, diarrhea, nausea, vomiting. Excuse me, yeast infections, we might want to say you can take a probiotic. You can have some yogurt with this. You can see some vaginal discharge. Some of the less common ones are headache, agitation, fatigue. Again, always a risk of an allergic reaction, especially if we've never taken it. Sometimes with antibiotics, we don't know until the patient takes it, and then we can document and always prescribe a different one if there is a known reaction to that drug. For monitoring, there's no labs necessarily required to monitor these, especially in Emily because she's a healthy individual with no medical history. It's important to monitor symptoms. We want to know how the lesions are healing. Is it healing with just the mupirocin, or do we need that oral antibiotic as well? We should start to see improvement in around 3 to 5 days. And we want to kind of discuss what the normal course of treatment would look like, how the lesions will appear, though it's normal to have that honey crust. They will eventually fall off. A lot of patients call in thinking that there's an infection when really that crusting is normal. We do want to talk about what cellulitis would look like: red, hot, raised. If we're noticing any unusual discharge, that's when we want you to call us, especially so we could have you come back in. And if needed, we could always do a swab and culture it and send it out just to make sure that there's no other strand of bacteria. For non-pharmacological treatments, hygiene is a major one. Good hand hygiene, respiratory etiquette, so always covering if you're coughing, elbow tissues. If you do cough in your hands, wash afterwards. We want clothing, linens, towels used by someone else with impetigo that should be washed every day. We want it washed on warm or hot water. They should not be shared with others. And I do see that I did not finish my reference there, so I will edit that afterwards, but I did get this information from the CDC. For skincare, we want to keep the affected areas clean. The overlying crust may be washed away gently, but we don't want to pick at the area. Or we want to use a gentle skin cleanser and water daily. We can also do saline soaks that can help for removing that thick crust. For education, for the mupirocin, we want to wash hands before and after applying the medication. We can apply a small amount to the affected area. You can use a cotton swab or gauze pad. And if you want to cover the area, you can, especially if there's drainage. And we want to just let the family know that this is external use only. We want to avoid the eyes, mucous membranes. And if it is ever in the eye, we want to flush the eye. And you could always call the office and we could advise on next steps. We do not use with other lotions and creams like we discussed. We can call the office if there's no improvement or if you notice any adverse effects, and we can discuss what next steps would be. For impetigo in general, we want to educate. We want to let them know that the honey crusting is normal. It's a common feature. And then after 24 hours on the antibiotic, the patient is no longer considered contagious, and we keep the lesions covered if draining because we want to make sure that we're not spreading the infection at all. These are my references. I'm going to leave my page up a little longer. I didn't leave it as long last time, so please take a look. If you have any questions, don't hesitate to comment. I hope that everyone's able to reply, and I look forward to watching everyone else's videos. Thank you so much. I hope everyone has a great day.